So when we look at the vocal folds here, we can see these ligaments. These are actually made of ligamentous material, which is dense, regular, collagenous connective tissue. So these are the ligaments of the vocal folds, and the space in the center is the glottis. So when we open up that glottis like this, we can breathe nice and easily. If we start to talk, force some air through there, extra air through there, then we have a lower voice. When we bring it together like this and force air through it, that's where we get the different inflections for speaking. So we can change the sound of our voice by adjusting the stretch of these vocal cords. Now, when they become inflamed, when you have, say, laryngitis, then they have a real crackly, and sometimes you only get a whisper that comes out, and that's inflamed vocal cords. And the best thing to do for laryngitis when you're losing your voice is to rest it. The more you talk through those inflamed vocal cords, the worse the voice becomes. And it's more straining on the vocal cords to whisper than it is to talk through them. So some people, when they're losing their voice, will whisper because you can hear better. You can make a whisper when you have laryngitis, and I know this because I used to get laryngitis every single year when I taught high school. And actually, laryngitis is the adult version of the croup. So my kids would get the croup, and then I would get laryngitis. So we all had the same bug together. But anyway, whispering is more harsh so it's better just to not talk if you have laryngitis, or to talk in your regular voice rather than whispering. So if we hold those two vocal cords together and completely close the glottis so no air can pass through, then we have what's called the Valsalva maneuver. I think we talked about that a little bit with the autonomic nervous system, stimulating that vagus nerve. So that increases abdominal pressure and thoracic pressure, and happens reflexively during a bowel movement and during childbirth. And you've heard of people that, they're in the car, rushing to the hospital, baby's coming, that uterus is contracting all on its own, forcing baby out, and at the same time, reflexively, women will have that urge to push, and that glottis will close, and they'll just reflexively go into that, pattern of pushing and increasing that pressure. But unfortunately, when patients are in pain and they get up and they get scared, or they start to cough a little bit, especially on the unit I work on, where they have their post-bypass surgery, so their chest has been cracked and their chest is really sore, and now they need to cough, or they're in a lot of pain, they'll go, ooh, and that sound is the two vocal cords pressing together. They're increasing pressure in the chest. We want to increase pressure in the chest in someone who just had heart surgery? No. How about someone who just had gastric surgery? Do you want to increase pressure down there by doing that? No way. So we really got to be careful that those patients are not holding their breath, and tell them to breathe in through the nose, out through the mouth. And I can't tell you how many times you have to remind patients to do that, because another time that happens, and we had a patient actually pass away, they were due to discharge, or on the toilet, constipated, trying to have a bowel movement, and again, reflexively, the body closes those vocal cords and to increase abdominal pressure, and that lowered the heart rate. Person fell off the toilet, banged their head, and died. So very, very important thing to remember, this Valsalva maneuver. It stimulates the vagus nerve, which can lower heart rate, and if someone already has a low heart rate, that can cause them to pass out. The good news about the Valsalva maneuver, when would we want to tell people to bear down, other than bowel movement, childbirth? If it slows the heart rate down, when would we want people to do that? Yeah, if their heart rate is really high. Some people go into these patterns where their heart rate's in the 170s and 180s. If their heart is beating that fast, that's not giving time for the ventricles to fill, and that can cause reduced tissue perfusion. So we want to get those people to slow their heart rates down, so we tell them to bear down. Now, if you have a really weak elderly person, they can't bear down. They don't have the strength in their abdominal muscles to do that, so we just tell them to cough. And just even a little like that. I saw one 80-plus-year-old man. Everybody was gathered around the bed and said, bear down, and his heart rate was way up, and everybody's kind of freaking out. And I just said, and I was a new nurse at the time, but I just remembered this, and I'm like, cough, can you cough for us? And he just went like that, and boop, his heart went right back down into the 70s, just with that little, that's all it took. So remember that. You don't have to be, a rocket scientist, a cardiac physiologist to help your patient. Just tell them cough. Just these little things that if you know this about physiology can save a life. Because if he continued on at in the 180s for any period of time, that's bad for blood pressure and tissue perfusion. All right, moving on down then. The trachea has C-shaped cartilage here. So put this down. Point on here because I'm recording. So it's C-shaped cartilage, which means there's only cartilage around the front of your neck. In the back, there is no cartilage because the esophagus is there. And when you swallow a big chunky piece of pizza and that esophagus kind of balloons out, that can push into the trachea because we can't breathe and swallow at the same time. So here's the esophagus, which is collapsed, and then here's the trachea. It has this ring of cartilage. And what kind of cartilage is this? Hyaline. Yep, hyaline cartilage. When in doubt, say hyaline. That's the most common cartilage in the body. So, and then remember at the base of the trachea, I don't have that here, but at the base, right before it divides into the bronchi, is the carina, which has a sensitive mucous membrane that stimulates a violent coughing reflex if we get food or liquid there. And you really have to be careful with your patients. If you're giving them medication or a drink of water, let's say some of you are working in a nursing home and you're giving your patient a drink of water, and every time you help them get a drink of water, they start this coughing. And you know it's the carina because it's that coughing where they're turning red and they're, that kind of coughing. You know you're stimulating that carina and they're not swallowing well. And if they're not swallowing well, food and liquid is going into their lungs. And what can that cause when we get anything that's not supposed to be in the lungs? Pneumonia. We call that aspiration pneumonia. To aspirate means you're inhaling something into the lungs that shouldn't be there. That's why they don't allow you to eat before surgery, because if you should somehow vomit a little bit because of the medications they give you, the anesthesia can slow peristalsis and slow down the stomach. It can cause nausea when that happens. And then you throw up a little bit during surgery, and then you inhale that into your lungs. Now you've got a big problem with pneumonia, bacterial pneumonia. So really pay attention to your patients. If you find that they're coughing like that every time you give them a sip of water, or let's say you're in charge of feeding them, and they're coughing in that violent way, they need to be seen, and they need a swallow study done to make sure that we're not, introducing stuff into their airways. And what do we do for patients like that? That when you give them a little sip of water, they're doing this coughing thing. What can we do to help slow the movement of liquids into their digestive tract? Lisa, I hear you mumbling something. What? Yeah, you thicken it. We add these little, I know, it looks gross, doesn't it? You add these little powders to all their liquids, and it thickens them. And there's different thicknesses. There's one that's like thickness of honey, one that's thickness of like nectar, and another one is like pudding thickness, where you're actually giving them water on a spoon. And it's clear, but it can be apple juice, whatever. But they need fluids. So the good thing about it is we're giving them their fluids. It's just that they're, they need to be thickened so they don't slip down these airways and into the lungs. All right. So, and I see this especially when we're looking at people that have like cerebral palsy or brain injuries or, severe developmental delays. We've got to really be careful with that because these young people are in the hospital a lot with pneumonia because of that very thing. They can't swallow well. All right, so looking at the passageways leading to the lungs then. How do things change? The conducting zone means there's no gas exchange. We're just taking this air from the outside and we're getting it to alveoli where the gas exchange is going to happen. So we have this zone that gets the air to the lungs. And when we have people with emphysema and asthma and chronic bronchitis, what do we call those collection of diseases? You see it on TV all the time with the different medications. I take Advair for my COPD. Yeah, chronic obstructive pulmonary disease. So there's a whole host of, asthma, chronic bronchitis, and emphysema are the three most common forms of COPD that you see. So anyway, so there's problems within the conducting zone, and then also with some, also in the respiratory zone we'll talk about. So the conducting zone starts from the trachea to the terminal bronchioles before you get to those alveoli. So there's no gas exchange. That's the key thing. Conducting zone, no gas exchange. We're just getting that air to where it needs to be, where gas exchange will take place. So the respiratory zone is where gas exchange takes place. So we're going from the end of that bronchiole to the alveoli to get that gas, those gases moving. CO2 moving out, carbon dioxide coming in. And there are some changes along the way. In the conducting zone, we want to make sure that we're preparing that air for the alveoli. So we want that air to be warm, we want it to be moist, and we want it to be as sterile as possible, getting into those lungs. So what warms the air, did we say? The capillaries of the nose. But how about if your nose is plugged and you're only breathing through your mouth? Is there any warmth coming in through the mouth? Yeah, it's warm in our mouth, isn't it? Yeah, so we have blood that warms the air, blood near the surface of our mucous membrane that warms the air. Okay, so that's warming the air. And then we also need it to be clear of debris as much as possible. So what's going to trap debris on the way down? Cilia and mucus. Okay, and what's going to moisten that air? We just said it. So the mucus is going to trap debris. Cilia is going to move that trapped mucus debris. And the mucus has a high water content, so that's going to moisten the air. So we're warming it, we're moistening it, and we're trapping debris. And the cilia beat toward the digestive tract, because if you look in your notes, under the nose, we produce 1 quart of mucus every day. 1 quart. That's a lot. You know what a quart of milk looks like? It's the tall, thin, square container. It's a lot of mucus. So where does that all go? Well, we're swallowing all the time. You feel that little collection in the back of your nasal cavity every now and then? You need to swallow that. And that's cilia moving the mucus toward the back of your nasopharynx, and then you swallow it down to your digestive tract. And mucus in the digestive tract is a good thing because it helps move our stool through, and it helps protect your digestive tract. So good mucus production is okay. But some people with a cold have a lot of mucus production, and they might find they get the diarrhea from a cold. And that's just because there's a lot of mucus in that digestive tract, and it causes the stool to be a little extra soft. But anyway, so this mucus is trapping the debris. Cilia is beating it. So if it's in the lower airways, do you ever feel mucus collecting on your voice box, on your larynx? And then you clear your throat. You go, and which way does that mucus move? What direction? If you get mucus collecting right here and you go, which way is it moving? Up or down? Where would you want it to go? Up toward the digestive tract, right? So it's going to go up. Right at the top here is where the esophagus is, and then it's directed to the esophagus. When you swallow, epiglottis closes, and you move that mucus down the digestive tract. And when you are feeling mucus collecting in the back of your nasopharynx, then you swallow, and it moves backward down the esophagus, the pharynx, then to the digestive tract. So it's important. This mucus serves an important role. Think of someone who's on a respirator, though. Aren't we bypassing all that stuff? We're taking that tube and putting it down in the trachea. Aren't we bypassing all the good things that the nose and the mouth and the pharynx does? So do we need to humidify that air that we're pumping into their lungs? Definitely. Do we need to warm the air? Yeah, we do. And if we don't, that can do damage. So we really have to be careful. And in babies that are born with premature lungs, a lot of times they will have some lung damage because that artificial respiration we give them in those early days or weeks after birth can do damage to those tender alveoli. All right, so when we get down to the respiratory zone, we lose the cartilage to hold the airways open. We lose the cilia and a lot of the mucus production. So when you get down into the lungs, the only thing protecting those lungs from infection are, what did we say? That I said you exhale a bunch in your exhale? What's left for protecting ourselves from infection in the lungs? Sort of like little Pac-Men? Macrophages, yeah. So in the respiratory zone, all we have left is a little bit of mucus and macrophages. What's holding the airways open when you get down there? To the bronchioles. Those tiniest of airways leading to the alveoli. Smooth muscle. Yep, smooth muscle. That's all that holds them open. So if we have something in the environment that stimulates smooth muscle constriction in the airways, like allergens, histamine, that's going to narrow those airways, and that's what happens with people with asthma, is those tiniest of bronchioles leading to the alveoli are constricting. So we give them an inhaler, which counteracts and relaxes smooth muscle, and that allows them to breathe easier. All right, so looking at the tracheobronchial tree, notice at the bottom of the tracheobronchial tree are the bronchioles, and that's what leads to the alveoli. And if we look at this, we can see that if we look at the airways here, we can see that the two bronchi branch here, and the right bronchus is more vertical than the left. And as a result, if we would choke on something and it gets trapped in a bronchus, it's usually the right bronchus that it gets trapped in because it's more vertical than the right. And remember, we have a primary bronchus, which is the first branch of the trachea, is the primary bronchi. And then this primary bronchi branches to serve each lobe of the lung. So here's one branch, here's another branch, and here's another branch. So there's three secondary bronchi on the right, and there's two secondary bronchi on the left, because there's only two lobes on the left. And then there's tertiary bronchi that serve each bronchopulmonary segment of the lung. So there's a lot more tertiary bronchi than there are secondary and primary. And then this tree branches 26 more times before we reach the bronchioles. So what we see here is only the beginning of this tracheobronchial tree. It branches many more times before you get out to the alveoli. So think of it like a tree. The trunk of the tree is the trachea. You have two main branches, which would be the primary bronchi. Then the next smaller branches would be the secondary. The next smaller branches would be the tertiary. And then you have all those tiny branches leading to the leaves, right? All those tiny branches is what we're not going to name because there's just so many of them. And what would the leaves be analogous to then in a tree? The alveoli, right? Where gas exchange takes place. Okay, so here's a bronchiole. We can see that it's mostly smooth muscle. And what branch of the autonomic nervous system dilates the airways, did we say? It's going to relax this smooth muscle. Do you remember? Well, think fight or flight. Which one is fight or flight? Which one is rest and digest? Which do you need to breathe for really well? Do we need to breathe more when we're chilling out, resting and digesting, or when we're fighting or flighting a bear or stress? We need to breathe more for fighting and flighting, yeah. So which division is that? Sympathetic. So the sympathetic nervous system dilates the airways. It's going to relax this smooth muscle. Do you know what a neurotransmitter or hormone of the sympathetic nervous system is? If someone's all cranked up and they say, oh, blankety blank kicked in and I fought the bully. What do we call that hormone? Adrenaline. Okay, another name for it is epinephrine. So epinephrine is something that relaxes the airways. And have you heard people that are prone to bee sting or allergic reactions from bee stings? What do they carry with them? EpiPen. What does epi stand for? Epinephrine. What is that? Adrenaline. What is it a result of, or what does it stimulate? Sympathetic nervous system dilating the airways, because that's the biggest risk factor when someone reacts to a food allergy or a bee sting, is constricted airways and they can't breathe. And I read an article about a family who had a daughter, she's about 13 years old, who had a severe peanut allergy, and she was at a Bible camp, and somebody made Rice Krispie bars, and there were peanuts in them. And she always went to this church camp, family was there, and it was a family, retreat or whatever, and they always, went, and everybody knew about her peanut allergy. Well, somebody was new to the church, made these Rice Krispie bars, which she has been approved to eat, so she had always eaten these at camp. Somebody new made the Rice Krispie bars, had peanuts in it. Her father was a doctor. So she said she tasted it, and she said, oh my gosh, she could taste the peanuts, and she was dancing with her friends at this retreat. Ran over to her parents and said, there was peanuts in the Rice Krispie bar, I spit it out, and I think I'm okay. So the parents said, well, come sit with us, we've got your EpiPens, sit with us, I'll give you an EpiPen right now, we'll make sure that you're okay. So she sat with them for about 15 minutes, she said, I really feel okay, I spit it out. Okay, go dance. Went back out and danced, all of a sudden she vomited, and then her airways started to restrict, and the father gave her a second EpiPen, because he's a doctor, and the last word she says was, Mom, I'm so sorry, and she passed away. And how serious is that? And this mother is reaching, my hair's standing up as I tell the story, it's so sad, but the mother is reaching out to the community, and the nation in this article, I forget where I read it even, but saying, take these peanut allergies serious, please. And I recently went to a preschool gathering for my daughter, and the teacher said, we have a peanut allergy, so if you bring something with peanuts, just make sure you label it. And thinking, is it that important we bring something with peanuts? How about we just don't bring anything with peanuts? Tell the whole school, don't bring peanut treats. We don't need to have peanut treats. If somebody has a peanut allergy, that peanut allergy can get more and more serious. Remember we talked about their immune response? And the first exposure, you might have a little bit of a reaction. The second exposure, huge reaction. So it's really important we take peanut allergies seriously. So if you know of people with peanut allergies, or you hear about it in the schools or whatever, spread the word. Just don't bring peanut treats. It's not that important that we eat peanuts if someone's life is going to be at risk from a peanut allergy. So that would constrict, the allergic reactions can constrict smooth muscle, and epinephrine can help dilate that. So in minor reactions, a little shot of the EpiPen, everything's great. But in severe reactions, like this girl, she had 2 doses of Epi, and it wasn't enough to save her life. So very, very sad. So then we can see that smooth muscle ends, and now we're into the alveoli. So we have simple squamous epithelium that makes up the alveoli. And what's the benefit of simple squamous epithelium? What does simple tell us? 1 layer of cells. Squamous tells us what? Flattened cells. Yeah. So what is the benefit of having 1 layer of flattened cells down in these alveoli? Yeah, quick diffusion of carbon dioxide and oxygen. So oxygen coming in is going to diffuse into the blood, and see the capillaries here? These are the pulmonary capillaries. So the pulmonary artery, right, leads to the pulmonary vein, but what bridges between them are these pulmonary capillaries. So oxygen and carbon dioxide are diffusing right here. And they wrap around the alveoli, kind of like a mesh bag you see for soccer balls. Those would be like the pulmonary capillaries. So they're right in contact. And what are the capillary walls made of? Studied that with the blood vessels. What would you think if you were going to design this body? If you want rapid diffusion of substances, what would you make capillaries out of? Yeah, simple squamous epithelium. So now you've got 2 cell layers right next to each other, 2 thin cell layers with carbon dioxide and oxygen on either side, and they could quickly move across. So carbon dioxide and oxygen only need to pass over 2 flattened cells. How many membranes total, though? 1 membrane to get into the, out of the capillary wall, from the inside lumen, and then the other membrane on the other side of that capillary wall. So a total of 4 membranes, right, to get across, 2 membranes per cell. But it's pretty quick. So very important that we have simple squamous epithelium. All right, so the respiratory membrane, you have a homework assignment on Blackboard. Make sure you print that off and start to work on this, or at least bring it to class, because some of the stuff we're going to talk about it, and you can start filling it out right away. And first is on the second page of that homework assignment is the respiratory membrane. So basically what we're looking at here is we have the alveoli in the center. This is a macrophage right in the alveoli to help fight infection that might get inhaled, because we're inhaling stuff all the time. Our airways can't clean everything out. And then we have these pulmonary capillaries. This is a cross-sectional view. So here's a pulmonary capillary that's wrapping around this alveoli. So carbon dioxide in the blood from the tissues is going to be diffusing into the alveoli from high concentration to low concentration. And oxygen in high concentration here is going to be diffusing into the pulmonary capillary. So we have this exchange here from the alveoli to the pulmonary capillary. So here's just a zooming in of the 2 membranes that are in contact with one another. So here's the plasma membrane of the alveoli, the simple squamous cell. Here's the plasma membrane of the capillary, again, simple squamous. And there's a small little space between them called the interstitial space. And then there's this basement membrane, which is just kind of a sticky surface on the outside of the alveoli that helps connect these 2 membranes. But again, it's 2 cell layers thick. We have simple squamous here and simple squamous here. So we call this the respiratory membrane. So if on a test I asked you what makes up the respiratory membrane, what would you tell me? What 2 structures make up the respiratory membrane? One is the alveoli membrane, and the other is the Pulmonary capillary membrane, correct. So make sure you be specific. Don't just say capillary. What capillary? Pulmonary capillary. So the capillaries of the lungs, right? Like I said, the second page of your homework shows that.